Bismillahirrahmanirrahim. Hi everyone. So this is the first video of a series about chest pain, a very common and important topic to discuss. So we are going to talk about differential diagnosis of acute chest pain. We're going to talk about the common causes and less common causes and the important causes. And then the rest of the videos will be specifically about acute coronary syndrome, definitions, different types of acute coronary syndrome, history and examination in acute coronary syndrome, and then the ECG findings in acute coronary syndrome, and then of course the cardiac biomarkers in acute coronary syndrome. So hopefully it will be a useful series, and I will try to make it as practical as I can. So in this video, I'll just give introduction to chest pain in general, the important causes that hospitalists and those who see patients presenting with acute chest pain should pay attention to. So we all know that chest pain is a really important symptom that has a very important differential diagnosis. But generally, I think one of the main reasons people care about acute chest pain is that we don't want to miss an important cause of chest pain, right? So as you can imagine, in the outpatient setting, in the primary care, those who are presenting with chest pain, usually less severe, most of the time it will be like non-cardiac in origin, like 70 to 80% maybe. But in the emergency department, this percentage actually goes down. So almost like a 50-50 chance of having a cardiac chest pain in patient presenting with or cardiac cause in patient presenting with chest pain. Now, really what matters is there's been reports and studies showing that about 2 to 6% of patients with chest discomfort presumed to have non-ischemic etiology and who are discharged from the ED because of that. They were later deemed to have a missed myocardial infarction. And these patients, unfortunately, as you can imagine, they have higher mortality. So these are really kind of a target for most of the discussions about chest pain and most of the protocols that's usually implemented in acute chest pain unit or emergency department to make sure that we do not miss this patient population. Age is very important in the differential of chest pain, as you know, and with the vast majority of causes of chest pain being renal and cardiac in origin in patients who are really young, less than 45-year-old. And as we grow older, as you can imagine, the cardiac pathologies become more and more important and more common. Nevertheless, still the vast majority, most of the patient who's having chest pain is probably going to be non-cardiac or less serious cause. But the caveat is you don't want to miss those with serious etiology, including the patient with myocardial infarction. And as you probably know as well, the top 3 differential diagnoses of chest pain or chest discomfort is really GI causes and cardiac causes and chest wall causes. It's like almost close percentages, like almost close to one third, and then with the rest of the causes taking the other percentage generally. So these are really the first thing that comes to mind when you have someone coming with chest pain. Is it really cardiac in origin? Is it coming from the stomach or the esophagus? Or is it coming from the various musculoskeletal components of the chest wall? So generally there's, as you know, a lot of differential diagnoses for chest pain, but it's useful, I think, to think of those who are like more common to be seen, especially for me as hospitalist in the hospital or in the emergency department. So these are pneumonia, probably the most common one, usually relatively straightforward to diagnose, even the other constellation of symptoms associated with that. And then myocardial infarction or acute coronary syndrome, pulmonary embolism, pericarditis, aortic syndromes, tension pneumothorax, and esophageal rupture. So these are the ones that probably important in order of which one is more common than the other. But I think for me as a hospitalist specifically, it's really more useful to think of the causes of acute chest pain as which one I really don't want to miss, which one has associated with more fatality or mortality. So usually I don't want to miss aortic syndromes. It's probably the first thing that comes to my mind. And then esophageal ruptures, usually the history can be straightforward, but not always. Sometimes can be very tricky. Tension pneumothorax has high mortality as well. Luckily, imaging usually gives you the diagnosis. Pericarditis usually doesn't have a lot of mortality on its own, but when it's associated with tamponade, the mortality goes up. And PE and MI, also both of them associated with high mortality if they are associated with shock, cardiogenic shock in MI or in massive or submassive PE pulmonary embolism. So these are usually come to the mind of physicians readily. But especially PE, can be really sometimes tricky to diagnose and can fool you. And then again, pneumonia is common, but unless it's really severe, mortality usually is not as high. But it's among all the infection, of course, pneumonia is really serious and important cause of mortality. So again, always remember these 7 differential diagnoses in your mind when you see a patient presenting with acute chest pain. So what are the other presentations that come with chest pain that should make you really worried? So chest pain that peaks within a second or a few minutes should be really suspicious for acute dissection or acute aortic pulmonary embolisms and pneumothorax. These are usually pleuritic in nature. So if the pain started really quick and peaked really quick, you should think of this most serious differential diagnosis. Of course, these usually do not last for seconds. So if it peaks in a second but it lasts for seconds, this is less likely to be cardiac invasion or serious. And then acute shortness of breath. Chest pain with acute shortness of breath is always concerning. It makes the GI and musculoskeletal causes less likely. Syncope or pre-syncope, you think of decreased perfusion to the brain due to aortic dissection, pulmonary embolism, or arrhythmias, decreasing the cardiac output. Confusion or alternative status is always concerning. Chest pain with focal neurological symptoms. Acute aortic syndrome should be in the top differential, specifically aortic dissection, because these can obliterate the origin of the carotids which supply the brain and can lead to focal neurological deficit with if it's also affecting the coronary sinuses or coronary arteries. Chest pain with severe nausea and vomiting. It could be cardiac, it could be non-cardiac. Esophageal rupture. Sometimes if the patient has a lot of nausea and vomiting and then followed by chest pain, you think of esophageal rupture, but sometimes the chest pain can be the first symptom followed by GI symptoms. And then, of course, you still have to consider other GI causes, like causes of abdominal pain that present in the epigastrium or the upper abdomen, as we talked about in the videos about abdominal pain. And then chest pain with sweating. Patient looks really sweaty. That's concerning. So as you can see, really, history. This is really the most important part in evaluating patient with chest pain. Try to understand the circumstances following the chest pain. You all know about all the 9 famous point histories that we take for any pain. Chest pain is not an exception, so always try to tease that out. The onset, the duration, the quality, associated symptoms, all that is really important. So history is really key, as you know. Abnormal vital signs, of course. Chest pain with abnormal vital signs is always concerning. And then, the eyeball exam, just looking at the patient, a lot of times you can really tell if the patient is having any serious cause or not, just by looking at the patient. So after history comes physical exam. Physical exam can sometimes give you useful clues. Sometimes it could just be normal, right? We talked about the general appearance. People with chest pain, if they look sick and in distress, might be more concerning. Any others or atherosclerosis that might indicate increased atherosclerosis risk, like increased weight, or lipid deposit like omas and metas, or less commonly, patient who are tall and young and thin, or has some Marfan symptoms, might present with acute aortic syndromes or pneumothorax, these kind of things. Vital signs, blood pressure and pulse. Whenever you have patient with acute chest pain, I hope this is done always in the ED. I really advise that you check pulses in both arms and blood pressure also in both arms as part of the evaluation of acute chest pain, because sometimes it can be really a major clue in the differential diagnosis for serious causes like acute aortic syndromes. And then absent pulse during inspiration, maybe not many people do that, but if you're suspecting pericarditis or tamponade, it could be useful to do that. It's very simple, and it has high specificity for tamponade if you can detect it, although of course its absence doesn't make any difference. Cold extremities is really concerning. If you have a patient with acute chest pain, they have sweating, they look sick, and they have cold extremities, you want to rule out cardiogenic shock in this patient. Examination of the legs. Look for pitting edema, could be a sign of cardiac distress or heart failure. Signs of DVT, could be a sign of PE or pulmonary embolism. Signs of peripheral arterial disease could indicate that a patient has a high risk for atherosclerosis and MI. Rashes, for example, with immunodosum in patient with pneumonia or mycoplasma or other causes of pneumonia. Could be a useful clue. I have seen that many times in Fresno where I practice, because we have a relatively high incidence of coccidioidomycosis, which is also a known cause of immunodosum in some patients. Examination of for JVD is important, especially for pathologies of the right side of the heart, like right ventricular failure or tamponade or pulmonary hypertension. Examination of the heart is really important. Again, sometimes, most of the time I would say probably normal, but sometimes you can have some clues. Levine sign, a sign is not very useful. This is when the patient is clenching their hand over their sternum. Of course, if it's absent absent, doesn't make any difference. If it's present, it increases the likelihood of MI a little bit. The likelihood ratio is about 2. Not very high, not very impressive, but still useful to consider. Palpation, important. Local tenderness might indicate a musculoskeletal cause, although I think about 5% of patients with MI might have some local tenderness too. Hyperesthesia, if you're thinking about like herpes or like neuropathic chest pain, important to bear in mind. Cutaneous crevitis is important as well. Percussion, not usually done over the precordium, but if your patient doesn't have a clear history of COPD or hyperinflation and they have history of smoking and they're presenting with acute chest pain, thinking about pneumothorax, for example, sometimes it can be useful. And then auscultation, looking for loud P2, might indicate pulmonary hypertension. Murmurs like aortic insufficiency, which might indicate like acute aortic syndromes or section or aneurysm. Ischemic mitral regurg murmur, not very commonly found, but sometimes in patients who already had MI, a few days later they might have complication of MI, but these days really it's not common at all. Added sounds like third heart sound, which you might see in heart failure patient, or fourth heart sound in patient with increased pressure in the left ventricle. Friction rub, also not commonly found, but it's one of the diagnostic criteria of acute pericarditis, so it's useful to look for if you're familiar with it. And examination of the chest, again, looking for rash, a neuropathic cause of pain, like in herpes. Palpation, again, subcutaneous emphysema in the front of the back or the back of the chest. Localized tenderness or musculoskeletal cause. Dermatomal hyperesthesia, again, also if you're looking for neuropathic pain. Auscultation, reduced breath sound, and hyperinflation. Patient bronchial breathing, basal crepitations or wheezing also might indicate like a pulmonary pathology as a cause of the chest pain or respiratory symptoms. Gastric pain or right upper quadrant tenderness sometimes might be a clue for an upper abdominal cause of the chest pain, which is not very common, but it might happen, so bear that in mind. Shoulder examination, sometimes patient with a lot of shoulder pathologists sometimes can present with like regional pain around that shoulder, maybe a little bit towards the lateral chest. So it's useful to ask about symptoms associated with movement of the arm and shoulder specifically, and examine also if there's suspicion to have a shoulder pathology. And then of course focal neurological deficit, we talked about that, could be if it's present or new with acute chest pain, might indicate aortic or acute aortic syndromes. Examination, I think, is very important sometimes. Patient who might have some risk factors for osteoarthritis of the cervical spine, and some patients might present with chest pain because of that. And then in that case, you do upper extremity motor and sensory examination to see if there's any neurological signs to suggest that the origin of the chest pain is actually from the neck rather from the heart. So what are the basic tests that you should probably order in almost all or most patients with acute chest pain? There's 5 of them. Obviously, ECG, it's very important to get it in a timely fashion, and you get it in intervals. We'll talk about that when we talk about ACS. Cardiac biomarkers, most of the time nowadays people use the hypersensitivity cardiac troponin. There's 2 of them, cardiac troponin I and cardiac troponin T. In my hospital, and I believe in most other hospitals, they use cardiac troponin I just because it's more specific and quicker to rise and fall. But both of them showed better results compared to the traditional troponin that we used to have before. And then the D-dimer, I think it's a useful test. It has really good negative predictive value. And just for PE, but I think even, for example, in the aortic dissection, if it's negative, it makes dissection less likely. Of course, it doesn't rule it out totally, but helps to make it less likely and prioritize the workup accordingly. And then BNP also can be useful. It might indicate like ventricular stress from causes like MI or heart failure or pulmonary embolism. And then lastly is the chest X-ray, also can be useful. I'll talk about that next. So when we talk about the chest X-ray, of course, a lot of the important causes of acute chest pain, because in the chest X-ray could still be normal, right? So myocardial infarction, PE, in sometimes in aortic dissection, chest X-ray might not reveal what's going on. So you have to keep that in mind. Some findings that might be useful, finding of cardiomegaly might indicate, for example, like an MI or pulmonary embolism or acute pulmonary hypertension. Wide mediastinum, you might see that in aortic dissection or acute aortic syndromes. Pneumomediastinum, also you might see it surrounding the cardiac and aortic vessel silhouette. Aortic calcification might indicate increased atherosclerotic risk. Consolidation in any lung field may be associated with pneumonia, especially if you see air bronchogram. With some Kerley-B lines also in the inferior lobes, the patient with pulmonary edema and acute congestion from any other cause. And pleural effusion, very important. It might indicate cardiopulmonary process, but also, for example, in esophageal rupture, you might see trace pleural effusion, so it could be an important clue. Here also you look at the deep sulcus sign, which is a sign of pneumothorax when air is tracking anteriorly and inferiorly when the x-ray is taken in supine patient, like in ICU or ventilated patient, for example. We tend to look at the apices for pneumothorax, but if the patient is lying supine, the telltale sign might be the deep sulcus sign, which is basically you see a very black, deep, sharp area here with well demarcation of the diaphragm, and there will be like lacking of pulmonary markings, just like when you see it here in the upper lobes in pneumothorax. So keep that in mind. And then, of course, upper x-ray is taken in the semi-supine or semi-recumbent position or upright position. You might see the pneumothorax over there. Upper lobe pulmonary venous diversion or upper lobe congestion or Kerley A line, sometimes they're called. Also could be a sign of acute pulmonary edema from PE, from any cause of acute MI or any cause of acute left ventricular dysfunction. Rib fractures could be important. If you see that, maybe start looking for pneumothorax as the cause of the pain. If patient had a fall or trauma or something like that. And then subcutaneous emphysema as well, sometimes overlooked because we tend to not to examine the other parts of the chest x-ray outside of the heart and the lung. So if it's very large, of course, it would be quite obvious, but if you do not specifically look at it, you might miss it. And then as a supplement to physical examination, I love doing a point of care ultrasound. And we're going to have a separate video about the use of point of care ultrasound in evaluation of patients with acute chest pain. So this is introduction, and then the next video we'll start talking about some of these important causes. And then after that, then cardiac causes. Thank you.